And then we did our check off.
Y'all did y'all check off? This is proof I'm paying my debt to society. These are the concepts that you will be tested on. Specific. You see how specific I am? Very. Let's go over them real quick. Fundamentals, of course, the professional nursing roles. Give me some of the nursing roles. Now, what's the role of a caregiver?
Care.
Specify everything.
The blanket statement for all the roles.
Okay.
I won't get that wrong again. Unless you change the wording.
Hey, which goes back to rule number 1. What's rule number 1 in the U.S. of NCLEX? Read how? Read the question carefully. Okay? Don't play with me. Okay. Let's go over. Collaborator. What is that?
It's where we're working with interdisciplinary.
You're working with other disciplines and you're communicating with those different disciplines. Advocate, we already know. What's advocate?
For the patient. Yes.
Okay, not for the patient, but what are you doing? What does that mean to be an advocate? Standing up for the patient, respecting their rights, making sure respecting them too, okay? Or their preferences as well. We said counselor. What is counselor?
Is that the one that's making referrals?
That one's also making referrals.
Okay, so they have to do with emotions.
You're addressing the client's emotions, yes. Okay. Very good. Anything else with counselor? The main thing was referral, making referrals and
mental health, giving emotional.
No, not just mental health. No, no. So with counselor, whatever the patient need, what resources that they need, you refer them to that. So for example, I gave the example one time where the a young teenager was pregnant, so you're making sure you refer her to community resources, like maybe WIC, for example, so she can provide so that she can have a smooth pregnancy. You're also addressing the emotions of the emotional well-being of that client too.
So counselors, community resource referrals, and collaborators. Which type of referrals?
You're collaborating with other healthcare providers. And remember, you're also making sure you're communicating effectively with those different providers. Then we have this section 2, health, wellness, and illness concept. All right, give me the different types, the 2 main types of assessment.
Subjective data and...
Okay, you taking too long, bro. You need to, that should have came out like that. You know what I'm saying?
Subjective and objective data.
Okay, good. What is subjective again?
What the patient.
What the patient tells you. Good. And what is objective?
What's measured and hear and.
Okay, what you can measure, what you can observe. Okay. Example of subjective data.
The patient feels nauseous.
Okay. Patient's O2 sat is 98. What is that? Subjective or objective?
Objective.
Patient said they feel hot. Subjective. Now, be careful if the nurse does their assessment and puts their hand on the client and they feel that the patient is hot, that becomes what now? Objective. Okay? So what am I saying to you? Read carefully. Also with regards to wellness and illness concept, you have different health models, one of them being the continuum. And what does that mean? The health continuum model?
Problems from birth to death.
From birth to, okay. Very good. Give me another health model.
Well, the health belief.
Health belief model. Let's talk about it. What's the health belief model?
The patient sees their own health as.
And what's health promotion model?
What motivates or promoting health.
Promoting health is in the name. Okay. What is another one?
The agent host.
Okay. Agent, host, and what else?
That's it.
No, health, agent, host, environment model.
Oh, sorry.
So that's like the Baxter model, right?
Yeah, because in other words, you and make sure. Now, I already told y'all already seen my questions, what it look like. The question is not going to ask you, what is the health continuum model? What is the health? No.
You have to recognize it.
You have to recognize it, okay? So you're going to be able, you should be able to see that, oh, I see a bug in the scenario. I see the environment or the setting is discussed, and I see the agent, which is the patient. If you see all three factors, then you already know when I ask you what health model is this nurse applying here? Agent, host, environment. Okay? Okay. Are we okay? Don't play with me.
Wait, can you explain the agent host one again?
Okay. So the agent host model, you need to, when the scenario is discussed, because I'm going to give you some kind of sorry scenario. Okay? You need to look at the scenario and see, is there a pathogen or a bug discussed? Okay? I might put like, I don't know, C. diff. That's a good one. C. diff. All right? The patient is infected with C. diff. You already got agent. You already got the host, right? And then in the they're in the med-surg unit. Okay, in room whatever. So you have agent, host, and the environment. Now, if I said something about like, the nurse is addressing the patient's perspectives on how they view health and stuff like that, which health model is that? Health. Yes. Okay. Now.
The stages of change model, right? Or is that not?
Okay, talk to me. I forgot about that one. Tell me about the stages of change model.
Stages of change is like the like addresses the patient's behavior.
Okay.
Like usually within like prevention, addiction, like weight loss, like somebody's perception of.
You do need to know it, but it's not gonna be on this exam. Oh, you know what, bro? Come on now. Yeah, I mean, this is, my exams are gonna be cumulative anyway. I gotta keep my promise, but no, I ain't putting it on this exam. It's not on this exam, okay? Damn, why did I say that? I should have made y'all study it. Okay. I promise. Okay, I promise. The stages of resistance model is not, it wasn't on here. What's on here, only what's on here. Okay? You see section 3? All of these, you can't play. Oh, I forgot, before I go into section 3. Chronic versus acute illness. Okay? Chronic illness, you gotta know, like it says, it's long-term and often it is irreversible. Often, key word, because there are some chronic illnesses that are reversible. The key word is that it's often irreversible, not always irreversible. Okay? Since that is chronic, then what is acute? Short term, Now, give me an example of an acute illness. Strep throat could be short term because that could be resolved right away. Acute, or flu maybe. Short term, something that's you caught it right away. Huh? A UTI. Now, if it's the first onset, because some people they have recurring UTIs and it becomes chronic. It can become chronic. Appendicitis. Appendicitis could be short term. Yeah, that's a very good one. Okay. Now, long term, something like COPD. In the word itself, it says chronic obstructive pulmonary disease or cancer. Make sure you identify the differences between acute versus chronic. And you are able to identify which of those illnesses can fall under acute or chronic. All right, remission. You should know this because you can't be a nurse and not know what it means to go into remission. And exacerbation is the other word. What is remission?
The disease is still present, just no symptoms.
Just no symptoms. You cool. Okay? We walkie-talkie. We still getting our swag on. But then exacerbation is what? Yes. Okay. Can you give me an example of a illness where you can see remission and exacerbation? Okay, cancer is a very good one. Cancer is very good. Okay, sometimes you go into remission and you show no signs, no symptoms, you're good, but then the cancer is still there within the patient. They just doesn't have any sign or symptoms. And then they go into remission when they start having those symptoms like nausea, vomiting, poor appetite, diarrhea, so on and so forth. Asthma?
Sickle cell?
Lupus.
No. Asthma patient, that's not a bad asthma. When you get an asthma attack, it could become a chronic thing. Sickle cell is another good example. Why you didn't want to say it?
Rheumatoid arthritis.
Oh, RA is a good one. We're doing good. Levels of prevention. You cannot go into the Board of Nursing NCLEX exam not knowing the levels of prevention and what they generally stand for. Primary, what is it?
So like immunizations, promoting health, right? So like.
What's the other activity? And
education.
boom. Very good. What's secondary?
Testing, pap smear.
Now, remember we had talked about how some of these activities, they can fall under primary. For the purposes of this exam, all screenings are secondary.
Diagnostic screenings.
Diagnostic screenings. I think
It's different. Well, there's diagnostic screens and then there's preventative
screenings,
But you're
yes.
saying for this
But for this
all
exam,
screenings are
all screenings are secondary. For this exam, okay?
Thank you.
Okay, people, you see, I talk to them, they better not give me no problem. And
Screening in the world.
screening is what? Secondary for this exam. Okay, when we go further into later in the term, then we're gonna find out how screening can fall into primary just a little bit. Okay, just like how we talked about first week. And then there's tertiary. What's tertiary? Treatment. Okay, this is when we're trying to keep you from going 6 feet under. We got rehab. Pay attention to the activities at each level of prevention. Pay attention to the activities at each level of prevention. Don't give me problems because I'm going to give you the look. Don't play with me. Okay? All right. And I wrote them down for you as your memory aid. Okay? And if you kind of do primary, you see P to P, S to S, T to T.
What?
On the memory aid.
Yes.
Y'all see that? Yeah. Okay. See? Yeah. Who's the coolest teacher? Yeah. You see, I hooked y'all up. Okay. You trying to remember? Oh, what the heck is primary? Oh, primary prevention. P to P. Secondary, S to S. Screening. For those of us who can really remember. Okay. Tertiary, T to T is treat. So when we treating, we at the tertiary level. Pay attention to the activities that are being conducted in that scenario presented. So when I ask you, based on these activities, what preventative level is this nurse conducting? If she treating that stroke patient, what's she doing? What level is that? Okay, you see? Don't play with me.
Pay attention to the activities
that are within the scenarios.
Okay.
So if you see she's treating an MS patient, what level of preventative care is she at? Tertiary.
Treating.
Okay, because you see treatment, you see tertiary. You see screening, we see
Secondary.
we see prevention, because nobody ain't got nothing. What are we doing?
Primary.
Care. There is teaching at all levels. We always educating, okay? Specifically when there's nothing going on with the patient. It is primary. Nothing's wrong. We're trying to prevent you from having something wrong. Primary. That's a very good question. Now, if she's teaching a patient who has high blood pressure and she's giving him medication and teaching him, and she's teaching him or her how to take the medication, what level of care is that? Okay, because there's treatment. If she's teaching, I don't want y'all to be like, but Professor Dr. Sammy, you said all teaching is primary, and I'm going to be looking at you like, hey, don't you see high blood pressure? Don't you see medication? Well, pay attention to the activity.
The primary is the prevention.
Prevention. Nothing is wrong with the client. So, for example, you a healthy client, and this is a safe community. I'm coming in to teach you about effective seatbelt use so you don't die. Good one, all right? That's what? Primary, okay? Don't play with me. Section 4, you already know. Since orientation, I've been bugging you about Section 4. Yeah, know the nursing process. No, what's assessment?
Gathering data.
Thank you. That's what I want to hear. Oh, keep it moving. Kiss that answer. Keep it simple. Assess is what?
Data.
Okay. Next is Diagnosis. Okay, what does it mean to diagnose again?
Label the problem.
Label the problem. Okay, based on what? Huh? Based on the assessment. If it's not in my assessment, it's not in my diagnosis. I assessed that a patient has a BP of 135/80, respiration 19, and O2, let me say even O2 sat is 98% room air. My diagnosis cannot be something like inadequate oxygenation. Where in my assessment is there inadequate oxygenation? You see? So if it's not in your assessment, it's not in your diagnosis. What else should not be included in your diagnosis?
Medical jargon.
People, don't play with me. You better make sure you read each option or the scenario very carefully.
No medical diagnosis.
No medical diagnosis. Yeah.
How's the patient gonna be on it?
Bruh. No, let me just address it. In your NANDA book, constipation is a nursing diagnosis. Constipation could also be a medical term because this is what the reason that they're here for. Maybe they had severe constipation and this is what we need to take care of. Okay? So a suggestion, even in the real world, a suggestion is not mandatory. The patient came in for constipation. Maybe in your nursing diagnosis, you're going to try to avoid using constipation, use something improper bowel movement or something like that. Okay? Your planning has to be how?
Smart.
What is SMART again? Specific, realistic, and time bound. When I write that goal out, that's what you're looking for. You have to be able to identify that this patient goal is too vague. For example, if my goal is for the patient is to be pain-free and I leave it at that, it's not smart enough. Okay? Patient will verbalize decreased pain level from 8 down to 10 within 4 hours of nursing intervention. You see that? So the more specific you are, the more measurable you are, attainable, realistic, and time-bound, the better. That's what you're looking for in these examples or these options that I give you in the next exam. Don't play with me. We cool? Okay. Then our implementation, nurse-initiated versus physician-initiated. Yeah, you need to know it. What's nurse-initiated? Define it for me first before I give me an example.
Done without a physician telling you.
Thank you. Okay. Now be careful with oxygen. I told y'all. It could be a medication. Yes. However, when is applying oxygen could be a nurse-initiated intervention. Patient is turning blue. I ain't got time to wait for the doctor to call me back 10,000 years later. So I go ahead and apply oxygen at 2 liters. Okay, no more than 2 liters, realistically speaking. If you find you need more, you really have to get somebody. If you can't get the doctor, you call rapid response code, whatever. Initiated. What's another type of nurse-initiated intervention? Ambulating the patient. You don't really need for the most part, it depends because some doctors will have to give you orders depending on after surgery, you know, how soon you could ambulate the patient. But if the doctor didn't give you an order, but you already know to prevent wound, that can be a nurse-initiated intervention. You didn't wait for the doctor to do that. Turning the patient every 2 hours. You don't always have to wait for a doctor to turn the patient every 2 hours. Patient crying, I handed them a tissue. You definitely don't need a doctor's order to hand a patient a box of tissues. I'm gonna look at y'all. Okay. All right.
Life-saving safety physical restraints.
Wait a minute. Say it again.
I said life-saving physical safety restraints.
Okay. Elaborate. What you mean?
Patient is actively combative towards self and others, and you have to physically restrain them in order to keep them safe immediately.
And you did it without a physician's order. Now, remember, that's because it's an emergency situation going on here. So yes, it is now a nurse-initiated intervention. Restraints will require a physician's order in any other non-emergent situation, where the patient is not a threat to themselves or to others.
But in that situation, it would start as a nursing.
Yes.
And then we would have to get the physician.
Thank you very much. Like as soon as yesteryear, you got it.
Prevention, wounds.
Okay, what about wounds?
Like they have a bed sore and you recognize it.
Mm-hmm.
You bandage it, or you care for the wound. You still have to document it and notify the physician,
Mm-hmm.
but then they'll know once you tell them, then they'll put an order for specific wound care, or wound care will
Very
be
good.
involved.
So she's saying, can wound care be nurse initiated? Yes, when you first see that wound whether it be like on admission, for example, yeah, it could be a nurse initiated. Yeah, I'm going to go ahead and provide wound care, document what I saw in my interventions. That's nurse initiated because I didn't wait for the doctor. Now it becomes physician initiated when the doctor provides specific orders related to the wound. Does that make sense? Okay, I give the patient a cup of water. Of course, there's no contraindication for me to give them fluids. That's nurse initiated. Okay, those kind of things. All right, very good. Okay, let me make sure I didn't forget nothing.
Like hygiene would be one too.
Oh, definitely. Bed bath. Okay? Anybody calling a doctor for a bed bath? We gonna have a problem. Okay. And then, of course, after implementation is evaluation. Remember, evaluation. Tell me about evaluation. I stress this so much.
Form of assessment.
Say it again.
It is a form of assessment.
It is a form of assessment. Don't give me headache. But for what type of assessment?
Reassessment.
For what? Looking for what? To see what? If your goals were met or not. Okay? And when is evaluation done?
At the end.
Say it again, please.
At the end.
Say it louder. When is evaluation done? At the end. Don't play with me. Huh?
End of what?
At the end of the nursing process. Okay? So you always start off with what? Assessment. And you go down the line to diagnose, to plan, implement, and then you evaluate. It has to be done in that order. You cannot go and intervene without first collecting data. You cannot go and intervene without first collecting data. Okay?
Yes.
Okay.
You say that one more time.
Don't go intervening without first collecting data, okay? Without doing your assessment. All right. Now, also, before I move forward, make sure, whether it be an assessment, and this is test strategy, people, whether it be an assessment or an intervention, it is the appropriate assessment for the situation. For example, I got a patient who is blood pressure is 135/80, respiratory is 19, okay, O2 sat 95, okay, I said 98, on room air. Patient is cool, calm, collected. I'm not going to go evaluate for a gangrenous toe. You see what I mean? So all the data, all the activities must correspond. Don't play with me. Nursing diagnosis and outcomes on section 5, they focus on patient responses. I stress this so much. Not what? Not the disease. Who is concerned with the disease? The doctor. Are we trained to be doctors? No. We are focused on how they respond to the disease. Your nursing diagnosis must reflect that. That's why you cannot have, or you must avoid as much as possible, medical jargon. All right? And of course, avoid labeling patients as non-compliant. That's like putting, it makes them look bad. Okay? So they do say, instead of non-compliant, say non-adherent. Okay? I mean, in the real world, if you say non-compliant, is it going to be a big deal? Bruh, it's not going to kill the patient. But for testing purposes, okay? refrain from non-compliant use, okay, or the verbiage. And then I already talked about the SMART. Now, communication, don't play with me. Board of Nursing, one thing you for sure are going to expect is communication, therapeutic communication. Please, guys, listen to me. Don't try to imagine how the nurse is saying the statement. Y'all got this habit of, oh, it sounded rude.
Yeah.
Y'all reading the thing, oh, it sounds rude. Like, how? Okay, is the statement true or is it false? Is it therapeutic or is it non-therapeutic? Guys, you must understand therapeutic communication does involve or entail simply stating the facts as they are. Like, patient is confused, sir. We need to put you back in your room. Don't try to imagine it like, oh, you need to go back to your room. No. Guys, be careful. Also, you...
Wait.
Yeah.
I got this wrong.
Okay,
We
talk.
talked about it, where therapeutic communication, when we're interviewing or trying to gather data from a patient, does not always mean that it is only open-ended statement, like questions or statements. It can be a direct question.
Yeah.
We're trying to get data.
Yeah, open-ended question does not mean the use of it is also can be therapeutic.
I feel like it's rude when you're like, oh, I'm sorry you feel that way.
No, you don't want to say that the board of nursing or even patients in general, they don't want your sympathy. Don't nobody want you to feel sorry for them. It's bad enough I'm here, they here in your hospital bed in the first place. I was supposed to be outside doing my own thing. Now I'm here laying in your bed. I don't want you feeling sorry for me. I want you to understand where I'm coming from. This is why you, as a registered nurse, as the great registered nurse, are going to allow me to verbalize and vocalize whatever I feel like saying. Okay? And your response in the US of NCLEX is going to be, you seem very upset today. Do you want to, how can I help you? Okay? Can you elaborate on that a little bit more? Meanwhile, patient is cussing up a storm. Okay? Oh, do you want to express your feelings or something like that? I've been looking at these questions. I'm like, there is no way, you know?
I told you everything I felt, and you're asking, how did you feel about that?
Yes. Okay. That's why I say US of NCLEX. Okay. All right. So that's what, in terms of therapeutic communication, please make sure you remember the different forms or techniques related to therapeutic communication. Yeah, it's going to show up in the test, one shape, way, or form. Open-ended, close-ended, so the ones? Reflection, yeah, all of those. Make sure you assess the different nonverbal cues and you look for specific incongruence. For example, my words that come out of my mouth as a patient doesn't match my action, the nonverbal cues. I gotta look for that because there's an inconsistency or incongruence there. You see why you got to pay attention to your client? You have to be very, very observant and you have to address that. And you're looking for the inconsistency between what is said and how they are actually acting. Okay? Cultural competent care. Don't play with me. What is the first thing they told us we got to do? Eliminate, say it louder. Biases. Okay? If I don't like culture Z, okay, I gotta address the fact that, okay, yeah, I don't like culture Z. I have a bias towards them. Culture Z make me sick. I can't stand them, blah, blah, blah. I'm a nurse. However, it is my civic duty. I took an oath to take care of the community. And it ain't about me. It's about protecting and providing care to the clients that come before me, all right? Or, under my care. So I have to address those within myself and eliminate it and go on ahead and take care of that patient without any biases or... All right, so you got to be self-aware and you have to be effective in your communication. She has a male client that speaks nothing but French. I'll tell you that. So what is doing this situation? Say it one more time, please, louder. You get a medical interpreter. Okay? Not the patient's family member. Not another nurse or healthcare provider who does or is very fluent in French. But in the real world, seriously, especially when it comes down to, let's say for a procedure where it warrants the patient's permission, you need their consent. If you do not document that you use an approved medical interpreter, you can get in trouble legally. Now, let's say the same French person, she got to who's very fluent, high and mighty. She be showing off with her French skills, okay? And she needs that consent yesterday because this is an emergency situation. She still cannot use, really, and I'm saying even in the real world, because there's this thing called connotation and denotation. Okay? So, and even if it's a and I'm gonna tell you why you can't even use a family member.
Because they don't understand.
Not only that, they may be able to understand because who's to say I want my family member knowing I got disease X? You know,
They're a nurse.
whether or if they're a healthcare provider or whatnot. I don't want my family member knowing this, so that's why you cannot use a family member even though they are very fluent. And even if now in the real world there are life-threatening situations that may warrant a decision like yesterday, that's different. Generally speaking, you avoid using friends, other co-workers or whatever. You should get a medical interpreter. Okay? Are we cool?
What if I'm just asking what they want to eat? Can I use Google?
Oh yeah,
I use Google.
Okay. She asks, what if you just want to know what they want to eat? Okay, that's not life-saving. Okay, for the US of NCLEX, you must use a medical interpreter. Because what if you thought Zorange was something else and Google gave you a whole different thing and they're like, that's not what I want. And they probably allergic to what you assumed that they wanted.
Yeah, but they got their allergy list.
Oh, welcome to real world where not all patients know that they're allergic to certain things until you expose it to them. Welcome to healthcare. Okay?
So let's say
Well, not always.
the patient speak another language, you're the nurse,
Mhm.
you're fluent in that language. But say for example you're doing a consent, but there's other providers, you're like a doctor, PA or whatever.
Mm-hmm.
You're fluent, but they're not. You still have to have a
Medical interpreter.
So you cannot act as a medical interpreter?
Nope. You were not trained in that. Now, if you were ever trained as a medical interpreter and you kept your training, your licensure or whatever, certificate, whatever, that's different. And even certain facilities might have policies against that too. So it depends on the policy. Let's say, for example, she is Haitian and her patient is Haitian, right? She still can, and she's very fluent in Haitian Creole. She still can. No, why? The connotation and denotation. Because
unless she's a certified.
not even, and that unless she's a certified medical interpreter, that depends on the facility. Okay, you got to be very careful because where she's from in her neck of the woods, they understand brown to be this word, and then she goes and interprets it from her neck of the wood brown, but in that patient's neck of the wood, brown is like another meaning, and then we done messed up the patient's care. You understand? So that's why you have to be very careful. Always use, especially in the US of NCLEX, no matter how minute or non-emergent, okay, medical interpreter, all right? Okay, boom, we keeping it moving. I talked about the therapeutic self-awareness. You see documentation? Y'all saw that nice little table I told y'all fall in love with? I hope y'all paid attention to it. Give me some unapproved abbreviations.
OD.
Say it louder. No trailing zeros.
OD.
OD. Oh, okay.
Yay! Scribbling. You have to.
CC.
Okay. No, why can't you CC?
I don't know, in the med book it says don't use CC. It says don't use CC, use milliliters instead because it can be confused with chief complaint.
Not only that, the way some people write their C's and the C's, it could be misinterpreted for something else because not everybody, But the main reason is that chief complaint. Make sure no trailing zeros. The medications, look at the meds. Okay. Now, if I wrote something in the patient's chart and I made a mistake, what do I do? No scribble, no whiteout, no nothing. Just what am I supposed to? Simply one line and an initial and keep it moving. Don't be extra with it. So make sure you know with regards to documentation, it is a legal record. Charting has to be accurate, timely, all right? Factual. Okay, people, remember, I gave y'all my example. Don't be, it's not 8 o'clock, it's 7 o'clock, and then that's when I'm charting that I gave my 10 o'clock medication. That's false documentation. Don't do that. Okay. Remember, documentation is always the last thing you do. You provide care to the patient, you intervene, you evaluate it, and when everything, you did what you had to do, when everything is said and done, go ahead and document everything in that order. Make sure y'all don't play with me on the military time, people. But for US of NCLEX, y'all need to know how to convert military to the, yeah.
In US, a real question, like legit, because it made my brain hurt a little bit. In US of NCLEX, how do they want midnight written?
Oh, they'll give you options 00. They'll put 00 or 2400. You can look at the options. They'll usually give you one or the other. Okay, good question. Make sure you remember the different types of documentation formats. Don't play with me, and when you would use them. Source oriented. What is source oriented again? That chart is divided according to the different disciplines. You got nurses, physician, all right, lab diagnostics.
So different charts.
Yeah, no, it's not different chart.
So it's an organization.
It's how the chart is organized according to the different disciplines. Source oriented records. Okay, so you're gonna have a section for the physician, a section for the nurse, a section for diagnostics, okay, so on and so forth. Then you have problem-oriented records. Your chart is organized according to the different problems, okay? And then you have SOAP. Again, it's pretty much self-explanatory. And then narrative notes, which is barely used, especially not in the acute care setting. This is the charting that allows the nurse to write freely. So if you want to write a dissertation, go on ahead and write a dissertation. You like free willy with your documentation. And then you have charting by exception. What is CBE?
Focus only on what's wrong.
Say it louder, please.
Focus only what's wrong.
It is not a documentation where you are documenting from head to toe. Pay attention. This is charting by exception, is you only charting what's wrong with the patient. So only what's wrong. They have a headache, boom. They got a granulous food, I'm putting on that. But if it's wrong with them, you're charting on it. It's not about pertinent or impertinent. So it's like, for example, if the patient has an unsteady gait, I'm charting on that. If the patient has constipation times 7 weeks, I'm charting on that.
So it allows us to just focus on the bad stuff.
On the bad stuff. I like that. So charting by exception, if it's an issue or if that's what they're complaining of, we're charting on it. Okay?
Freely? Or
No, not for. No.
I'm too confused.
Okay.
Well, I know you said the bad and then whatever.
No. Okay, hold on. Let's do because I'm on the problems.
No.
Narrative, you write whatever you want.
Got that.
Yes.
Okay, so are these document formats, are these based off of what system, like systems are set up a specific way, or I don't.
The format is for the facility, how they want the records to be organized.
Yeah.
That's just for facility use. Some facilities use source-oriented, like I believe maybe a lot of rehabs or long-term care facilities. And some facilities, most hospital, they do charting by exception. We only focus on what's wrong with you. Okay, your vision okay? We not charting on your vision. Does that make sense? Narrative charting, where you write free willy. It is a charting that is allowing the nurse to write whatever she wants. Free willy. There's no limitation. She wants to document on what's right with the patient. She can document on what's right with the patient.
So, if he's being agitated and not complying, and he says something inappropriately, she can quote that in there.
Yeah. And then she also wants to include how he wore blue shorts and he had a steady gait. He drank all his milk today and was happy about drinking his milk today. You want to include all of that? You can.
That's when she has time.
Okay, you see,
That's a nurse that
don't.
has time on their hands.
I already see. You see, I already see what my problem, student. If it involves legal protection, continuity of care, or communication, documentation is your priority. Now, remember, I said documentation is typically done when. At the end, it's still gonna be done at the end. You're still gonna take care of the patient and then document, okay? But you gotta pay attention to the question. If the question has now legal issues, okay, where, for example, family wants to sue because now the patient has a right hip fracture, or now how you document and what you document is going to be the priority, for example. And then ethics, don't play with me on the ethics. Give me one ethical principle. Give me one.
Non-maleficent.
I know y'all going. I know that's right. I know that's right. Okay. Justice. Fidelity. Don't be about fidelity or something. You better know what it is. Fidelity. Beneficence. Whatever we want to.
That's good.
Autonomy.
It was on ethical autonomy.
Yeah.
Maleficent.
Yes.
Okay. We got non-maleficence, autonomy. Okay. Any more? Or is that good? Veracity. There we go. Okay. Veracity is what?
Tell the truth.
Tell the truth, the whole truth, and nothing but the truth. So help you. We leave it at that. Okay. That's just telling the truth. In other words, you tell the patient, listen, your pain medication is due at 10 o'clock. That's just simply. Again, people, do not imagine how the nurse is saying it. I don't want y'all coming back to me talking about, oh, it sounded rude. Okay? It's 10 o'clock. She probably could be saying, oh, your medication is due at 10 o'clock. I don't know. Was it the truth or not? That's it. Don't play with me. Autonomy, y'all already know what autonomy is.
Go ahead.
The right what?
They have the right to
Make a decision. Okay? And remember, guys, autonomy is not limited to the patient. Nurses, healthcare providers also exhibit autonomous act. Beneficence, again, is what? Doing good. Non-maleficence? Avoiding harm. Then give me an example of non-maleficence.
Patient has low heart rate, and you hold a medication that would drop it even lower.
There you go. Very good. Okay, don't play with beneficence.
Doing some. Oh, you want like an example?
Yes.
Or, okay.
Example, please.
Okay. Example. They have a PRN medication for pain, and they have a high pain level, and I give the pain medication.
Okay, I get a pen. And y'all know what justice is. What's justice? What's justice? Guys, don't overthink. Fairness. Everybody's treated fairly, no matter how much money you got in your pocket, no matter where you come from, no matter your political stance. We ain't worried about that. Okay, in the U.S. complex. Okay, and we keeping it moving. All right? Everybody's treated fairly. Very good. Let's keep it moving. And then give me an example of... give me an example of the nurses keeping their promise.
Staying up to date on their education.
Very good. Staying up to date on their education. And what's another form of example of fidelity?
You tell them you're gonna come back in 15 minutes. Come back.
And you actually come back. Okay, all right. You see, I don't really need to do no review, guys.
Yeah.
Oh God. All right.
This is fun.
All right. Guys, do not play with me with prioritization. And what did I tell y'all to do with regards to prioritization? What are you thinking about? And remember, I told you, fan your priority questions. Remember, you prioritize, you choose the answer choice that is going to quickly address the situation presented in that scenario. Okay? Maslow's hierarchy of needs.
Maslow's hierarchy of needs addresses the priority of what people need.
Okay, all right.
Like we need like a specific level of need needs to be fulfilled before we can go up to the next one.
Okay, thank you. It's meeting basic human needs. People, don't play with me. Maslow's hierarchy of needs is meeting basic human need. Every human being has to have these needs met.
Yes.
Don't matter what your pocket's looking like, what political stance you are, where you come from.
Constantly recycling.
Yes. Okay, people, what is on the lower level? Physio. And then physio equals what? Oxygen, definitely. What else? Elimination, which is including defecation. Everybody gotta defecate. Everybody gotta urinate. Everybody gotta fart too, depending on what you eat, whatever. Okay? Boom, elimination. What else? Rest. Okay? Sleeping, same enchilada. What else?
Sexuality.
All right. Did I get everything? Fluid as well. Okay? It's on there. Huh? Bathing. Food. We said food. Okay, boom. After physio.
Wait, is pain a part of that too?
Oh, pain too. Now, hold on. With regards to pain, I don't think I did it on this exam. I'm not sure. Okay, but with regards to pain is typically considered psychological unless it interferes with care. So when pain interferes with care, now it becomes your priority. For example, you need to do a wound care dressing and the patient is experiencing a pain 10 out of 10. Well, your priority now is not to do the dressing. Your priority is to address the pain. Does that make sense? Okay.
So if it's causing a physiological, like there's a physiological issue.
Yes. Then pain becomes your priority. Because sometimes you're going to have patient, they complaining of pain 10 out of 10 in the right arm. And bro, that's not your priority. After physio, what's next got to be met? Safety. After safety, love and belonging. After love, self-esteem. And then after self-esteem, self-act. Okay, y'all know. Guys, when you look at the question, you see there's no physiological issue in the scenario provided, then you go look to see if there's a safety issue. Safety could be something like having the bed in a slow lock position. Hold on. Now, if this says, what is the nurse's priority concern, and you have put the bed in its low lock position or apply O2, what's the priority? O2. Okay? But safety first. Life first. There you go. Life first, okay? Be very, very careful. Don't play with me. All right? Again, now you look at the question. If there's no physiological issues, you go up the echelon. You notice in the scenario, there's no safety issue. Again, safety could also include infection control because that's part of safety. There's no issue of infection. Everybody wash their hands like they were supposed to, blah, blah, blah. Move up the echelon. Love and belonging. Okay, maybe they have a problem with their community or their family. That has to be addressed. Okay, if they have an option where what's the priority? Allowing the patient to express their concerns about family disowning them versus, I want to go travel the world. Which is your priority? Well, the love and belonging, because they don't have no family. Y'all understand? Yeah. Don't play with me. I'm trying to move faster. Boom. And then y'all already know airway, breathing, and circulation. For this exam, we're going to focus on airway, breathing, and circulation for this exam. And remember, I told you when you're dealing with CPR-related issues, later on, you're going to have to decide whether it's airway that's your priority or circulation that's your priority. You're just being warned right now, okay? But it's not on this upcoming exam. I'm going to go easy on you. So Maslow's safety principles, and again, remember, guys, you're going to see this a lot throughout the nursing program. Physiologic. Airway, breathing, and circulation. and then nursing process. You prioritize according to that. So, in other words, when you have a priority type question, and they ask you what should the nurse do first or what should the nurse do next, you consider, not in any particular order, but you consider these elements, okay? Is there an issue where I have to address the airway first, the breathing, or the circulation? So circulation could be something like the pedal pulses are diminished, or blood pressure is elevated or too low. So maybe that might become my priority. Does that make sense? Okay? Or the nursing process. Do I have enough information to even intervene? So if I don't have enough information in the scenario presented, my response should be an assessment-like response. If there is enough information, my response should be an intervention response. Now, people, again, pay attention. Is the assessment appropriate to the situation? Patient can't have a right fracture, and then the response talking about something, go ahead and assess and monitor for pedal pulses in the left limb. You see what I mean? So that's why I tell y'all, read carefully. Because nursing students, they love to go ahead and choose an assessment-like response. And then when they didn't read the end of that option where it says to assess for something that's completely has nothing to do with the scenario. Okay? I have some practice questions, and no, these are not going to be on the exam, but it's kind of similar. You see how much I like y'all? Thank you.